Welcome to another episode in Season 2 of the AOT Pod, a trainee-led initiative tackling key themes, insightful topics, and important clinical scenarios to help trainees pass the FRCS in otolaryngology. My name is Josh Michaels, Vice President of AOT and co-founder of the AOT Pod alongside Georgie Wellstead. And today, I'm grateful for the support of Ms Tharsika Myuran, an East of England trainee who has just completed the post-CCT fellowship in anterior skull base, rhinology, and facial plastic surgery in Wessex. Alongside Tharsika, I'm pleased and privileged to welcome Mr Ashok Rokade, skull base and facial plastic surgeon, chair of the Global Rhinology Network, president of the British Rhinological Society, and fellowship director of the Winchester Anterior Skull Base, Rhinology, and Facial Plastics Fellowship. Together, they will cover the intricate and nuanced topic of Epiphora. So without further ado, please enjoy.
Thank you, Josh and Georgie. Thank you so much for joining us today, Mr Rokade.
Thank you, TK, for hosting me. And also thank you, Josh and Georgie, for putting up your efforts in developing this very useful podcast series. And thank you to the whole team for this.
So just to start with, Mr Rokade, when did you take your exam and what was going on in your life at the time of preparation?
Oh, it sounds ever so long ago now. Very interesting period of life. You can never forget that. I think I was in my equivalent of ST7 that time and taking the exam. It was great fun, so to say, when you look back. It's a very stressful time as well, but at the same time, so very satisfying and rewarding.
What would you say were some of the challenges you faced when you were studying and how did you manage them?
Yeah, the challenges were logistics of your day-to-day job because although you're taking exams, you don't necessarily get long periods of time off. You have to do it alongside your clinical work, alongside your training commitments, and also not to forget your family commitments. For me personally, it was a happy time because we just had our second baby. Then that really makes the family dynamics interesting. Then my clinical job that time was almost an hour's drive away. So that was another challenge. So every day driving an hour each way and then doing a job, then on calls. So those were the challenges. But I think you work with the challenges, don't you?
Absolutely. And how did you feel and celebrate when you passed?
Oh, I think the first feeling was a sigh of relief. That is done. It's behind you and it's time to look forward now. So celebration wasn't much of it that I remember. It was kind of muted. It was more of a relief and happiness. Then there were many things to do from the career point of view, like immediately preparing for your ARCPs, the final year ARCP. It's equivalent, they used to call RETAs those days. And then preparing for getting the fellowship. And I was really keen that time to get my next Rhinology fellowship. So I was just started working towards it. And I was glad that I could get to one of the very prestigious fellowships at the time with Professor Nick Jones in Anshul Sama in Nottingham. And yes, so it all happened very timely and just as if it's planned.
That's really fantastic to hear. So coming back to our topic, Epiphora, could you explain your differential diagnoses for a patient presenting with watery eye and how you would clinically evaluate them?
As you know, Epiphora occurs when there is an imbalance between tear production and tear clearance. I want to make sure that all non-obstructional causes have been ruled out early, such as eyelid problems, ocular surface disorders, and hypersecretory disorders. Ideally, this patient should be assessed jointly with the ophthalmology colleagues in an MDT clinic, which we have long established in Winchester, and it's such a rewarding setup, and patients get enormous benefits out of it. I would take a thorough history and examine patients along with my colleagues. A pertinent history is essential to provide clues to the diagnosis. It can be subdivided into nasal, ophthalmic, and general medical history. History of sinus disease, sinus surgery, midfacial or ocular trauma, or history of nasolacrimal duct probing as a child may all suggest obstructive problems. In addition, pus or blood in the tear film may indicate infection or malignancy respectively. So these are some of the red flags. associated symptoms such as pain, itching, burning, etc. are important to elicit, as they may provide further insight into the etiology. Dry eye can irritate the eye and produce tearing, and the treatment for that is lubricant eye drops. Blepharitis can be treated with warm compresses. A full ocular examination is warranted to pinpoint the cause of watery eyes. The ophthalmologist should look for facial and periorbital asymmetry, eyelid malposition, and mid-face ptosis. Any inflammation, discharge, or fistulas should be noted. It is also necessary to evaluate a corneal surface, assess the blink reflex, and check for lagophthalmos. Fullness over the lacrimal sac region and or reflux mucopurulent drainage upon palpation of lacrimal sac may indicate dacryocystitis or a dacryocele. Nodules or firmness superior to the medial canthal tendon may suggest neoplasm. Obstruction, lacrimal drainage disorders can further be subdivided into the anatomical levels involved. It could be the punctum, it could be the canaliculi, or the nasolacrimal duct system itself. We usually use a blue filter fluorescein dispersion time test. It can also be useful where the time taken for the fluorescein to disperse should be ideally 8 to 9 seconds, but it shortens when, in cases of the dry eyes, for almost up to 3 to 4 seconds.
So, for the purposes of the FRCS syllabus, we'll discuss the surgical management of Epiphora with a focus on nasolacrimal duct drainage disorders. How would you describe the background pathophysiology of nasolacrimal duct drainage disorders?
Any condition that obstructs the lacrimal drainage pathway can result in tearing. It's really important to understand the anatomy of the nasolacrimal system at this stage, so that it helps to work out the level of the problem and the subsequent treatment. You can plan the treatment once you focused on the level of obstruction. Tears drain into the puncti at the medial canthus, as you know. There is an upper lid punctum and there is a lower lid punctum. Through the puncti, the tears drain into the upper and lower canaliculus, which join to form the common canaliculus. This then drains into the nasolacrimal sac, which then drains further into the nasolacrimal duct, which lies in the thick bone of the frontal process of the maxilla, and finally, under the head of the inferior turbinate, into the nasal cavity, popular exam question, the valve of Hasner. Then this punctal and canalicular stenosis can result from toxic medications, so like pilocarpine, epinephrine, phospholene iodide, idoxyridine, trauma prior to radiation therapy, chronic inflammation secondary to infection, or autoimmune disorders like ocular cicatricial pemphigoid, Stevens-Johnson syndrome for that matter. The nasolacrimal duct also may become obstructed secondary to involutional stenosis, trauma, prior surgery, post-irradiation, chronic sinus disease, then dacryocystitis, or granulomatous disorders. In addition, neoplasms can affect and obstruct any portion of the nasolacrimal system.
Excellent. So, how can nasolacrimal duct obstruction be investigated, and what would you say the critical findings would be of those investigations should you choose to do them?
Yeah, so as such, there's no really a consensus regarding the best way to assess the nasolacrimal obstruction. But I can tell you about our practice a bit. For the first time, uncomplicated presentations, an initial test is flushing of the puncti. After irrigation is introduced into the nasolacrimal system, resistance, reflux, and delay or lack of clearance into the nasopharynx suggests a presence of obstruction. The degree of resistance and reflux suggests the severity of obstruction. Whereas the location of the reflux helps to localize the obstruction. So, for example, reflux through the same punctum suggests canalicular obstruction, whereas reflux through the opposite punctum may suggest a slightly distal obstruction. Probing can also be helpful, where putting a probe into the punctum and feeling the canaliculi for a soft or hard stop. The soft stop is suggestive of canalicular obstruction, whereas the probe is met with the stenosis of the canaliculus and cannot pass further. So you feel it's very soft. Okay. While a hard stop, it suggests patency of the canaliculus. That means you have passed the canaliculus, since the probe has passed through, but it meets the hard bone which encases the lacrimal sac. So I think that differentiating hard stop and soft stop gives some indications. If there are doubts about the concurrent pathology such as malignancy or chronic rhinosinusitis, you can do a CT sinuses, which can be useful. In my practice, around 15% patients need that. For unclear cases and revision cases, dacry cystography may be useful to identify the level of obstruction and identify post-operative sump syndrome, which we will come into when talking about the operative management. So DCG, it's unclear when do you request that. So it's actually an anatomical test. Okay, it gives you some idea about the level of obstruction. It can also show you some dacryoleads and all that if they are present in the system.
Excellent. So what treatment options are available and what prior considerations must be made?
So it's very important to look into that. So the punctal stenosis and canalicular problems can be treated with dilation procedures. So usually the ophthalmology colleagues deal with that. There are punctal snip procedures. If there are any correction of eyelid issues, our ophthalmology colleagues can help you with that. Then if true nasolacrimal duct obstruction is suspected, then a full ENT history and examination needs to identify any comorbidities such as allergic rhinitis, CRS, and in pediatric population, congenital abnormalities such as cysts, membranous blockages of the distal portion of the nasolacrimal duct. Up to 20% of the patients may have concurrent pathology, which will need to be treated simultaneously, be it medical or surgical management.
So if it's a functional blockage, what would you advise your patients?
I think this is where you need to have a real conversation with the patients. First of all, if you're doing a functional obstruction, essentially that means there is no actual anatomical blockage, but there is a failure of the pump within the lacrimal sac to drain the tears. You can still offer an DCR. It's not a contraindication. You can still offer a DCR as long as you understand that the success rate drops down. The standard success rate in my hands is around 85% for standard DCR, where there is an anatomical obstruction. But for the functional obstruction, it drops down by around 10%. So I usually quote around 70 to 75% success rate if you do a functional DCR. It's still an option.
And then how about the discussion about whether to use an endoscopic approach or an open approach? What factors and considerations would you make there?
I think that's a very good question. The scar is a very pertinent factor here. You explain the patients about, you explain the options to them. So then it's a scar versus having no scar. In our department, we have almost our first preference to do an endoscopic approach unless there are any certain issues. Of course, endoscopy approach requires a general anesthetic, but the external approach often can be performed with local anesthetic if the patient's medical condition demands or is you are in that situation. So that's when we offer the external approach as well.
Mm. And then there's also the controversial topic of whether or not to use stents and how long you leave them in for.
Yes, that's a very another interesting aspect of a DCR surgery. The stents we're talking about, that the silicone stents, they're called as Bodkin's tube as well. And usually when I started my practice, I almost tried to use them in each and every patient. But now over years, I've become more selective. Although most of the stents don't cause any problems, we tend to leave them for 3 months and then take it out. But often, sometimes they can have excessive crusting. And on occasions, I have 2-3 patients in my career when the stent have sort of looped out and the patients have to come attend the emergencies and we have to deal with that situation. But overall, I didn't find much problems with the stents as such. But I've become a selective in the sense that if I find that during the probing, when we're doing endoscopic DCR, if there is an easy passage, seamless, without any obstruction, and you're dealing with the pathologies like dilated sac, the dacryoceles, then I would not put a stent in. But if you are struggling to get through, there's a feel that there might be a narrowing, there might be a bit of a fibrosis within the canaliculi. But in that point, then I would put a stent. And if I put stents in, I tend to leave in for 6 weeks or so. And also on occasion, sometimes the patients need long-term stents. Say some of these patients who have indication for LJ canaliculus, common canaliculus blockage. LJ tubes, glass tubes are indicated, but I have experienced a lot of problems with the glass tubes, and therefore, instead, we offer them the silicone tubes and see they leaving them on a long term. As long as they don't cause any problem, we just tend to leave them long term. So we have on occasions exercised that option as well.
Excellent. Thank you so much, Mr Rokade, for sharing your pearls of wisdom on this topic. Just to summarise, Epiphora is best assessed in a multidisciplinary clinic. It's important to differentiate between ophthalmic, nasal, and general medical conditions that can contribute to the Epiphora. When investigating, be cognizant about the anatomy involved and the different stages of the assessment, such as looking at the puncti, the flushing tests, and also during the procedure itself, being considerate of how easily these tubes are passing, so that you may or may not use tubes to give the best long-term outcome, the stents, of course. And not to forget that there are also indications for external versus endoscopic, but all in all, it's best done in conjunction with a multidisciplinary approach. So thank you so much, Mr Rokade, for that.
Yes, thank you very much, Mr Rokade, and thank you to TK as well for all of your great help. It really has been a pleasure to have you both as a guest on the AOT pod. And Mr Rokade, before we draw this episode to an end, is there anything you would care to add as your closing remarks?
Yeah, it's a privilege to have done this podcast. And one thing I would say from my personal experience that has been very rewarding area of practice. ENT surgeons should, or rhinologists, should definitely stay involved in it, actively seeking this practice. And it's not only the surgery, endoscopic surgery that you do, but it is also the multidisciplinary team working with the ophthalmology colleagues, and it is ever so satisfying and rewarding. I would highly recommend whenever there are opportunities, so keep this as a part of your practice as a rhinologist.
Well, I think that's a wonderful note to end on. So once again, thank you to TK and thank you, Mr Rokade. Special thanks must also go to Livy and Carla, our AOT podcast leads, the ENT UK Foundation Trust, and of course, to all of our listeners. Please do like and subscribe to our podcast channel. Write in to the aotpod@gmail.com with comments, queries, and episode suggestions. And please do make sure to keep up to date with all the things that AOT are doing to help support ENT trainees in the UK by visiting aotent.org. Thank you and goodbye.